argue about that later on. Now, the importance of wearing off is it eventually affects almost every patient who has Parkinson's disease. It also is not a phenomenon related just to the motor symptoms of the disease. It also contains elements related to non-motor symptoms. So a patient starts to turn off and they start to exhibit anxiety or apathy or other non-motor symptoms. So it's not just loss of motor function with a shortening of the duration of the drug. And the message of this whole talk is that wearing off can be treated effectively if you deliver drugs more continuously into the brain and into the basal ganglia. What sort of incidents are we talking about? This is just one study, and you'll see that in this study, I don't know, between 30 and 70% of patients exhibited wearing off at some point during the course of their illness. This is just one study. Other studies show slightly different figures, but usually in about the same range. Now, the important thing to notice is if you look at the second group, 13 to 24 months, then you've already got about 50% of patients showing wearing off at a very early stage in their disease. And that's important because most people think wearing off is a late stage phenomena in the treatment of Parkinson's disease. And in fact, it's not. And a few years ago, I published this paper along with Fabrizio Stocchi and Jose Besa. And the idea of the paper was to make the point that often wearing off in form of motor fluctuations is there much earlier than you think. Sometimes it's there earlier than even the patient thinks. It's not recognised, and what you have to do is pick it up early so that you can treat it early. Now, my role in this paper was very clear. Fabrizio Stocchi is Italian. Jose Besa is Spanish. I had to translate Italian English into English, and I had to translate Spanish into English. But if you read this paper, you will see that it's not a simple task, and it's one of the most complex papers that I've ever written, and I struggled to understand it myself at times. I freely admit that. Now, Stocchi took this on a bit further. Stocchi led a study called the Deep Study, and what he did was he went and systematically and quantitatively looked at when wearing off occurs in Parkinson's disease. And the results are very interesting. If you look at patients with less than 2.5 years of Parkinson's, then neurologists, you, diagnose wearing off in about 22% of them. If you use a questionnaire which the patient fills in, 42% report they've already got wearing off by 2.5 years. This is something which is not late, it really does occur early. And if you go on later, they went on to 6.5, 7 years, then what you find is that the neurologists catch up a little bit. 57% of neurologists diagnose wearing off. Patients themselves diagnose wearing off at 67%. So it's an important phenomenon, but it's an early phenomenon. Now, what causes wearing off? So we're talking about the shortening of the duration of effect of each dose of levodopa that occurs with progression of the disease and with the duration of treatment. Sharper, shorter bursts of activity. The first thing to make clear is this is not a pharmacokinetic change. This has got nothing to do with plasma levels of levodopa at all. Unless the patient has gastric paresis, and then you might get delayed absorption, you might get dose failure, but under normal circumstances, nothing changes in the periphery at all. The drug is there, it peaks at the same time, it goes away with the same time course. This means that wearing off is a centrally mediated phenomenon that takes place at the synaptic level. So this is pharmacodynamic and not pharmacokinetic. Okay, is that clear? Good. Now I have to explain something which is probably the most complicated thing in the whole lecture. And I have seen my colleague Fabrizio Stocchi try and do this and die on stage trying to explain it. So I'm going to try and make it as simple as I can. You have to understand something about the action of levodopa that most people don't appreciate. And that is, there are two components to levodopa's actions. There is a short duration response, which is the effect you see when you give a patient an acute dose of levodopa. Little dose, they turn on, they stay on, and then after a few hours they turn off again. Okay? That's a short duration response. And that's what you see on a regular basis. But when you start levodopa treatment, you will find that the maximum effect of that dose of drug is not seen after day 1. You will probably see the maximum effect of that dose regime after day 7 or day 14. There is a long duration response which builds up over time for levodopa. And if you were brave enough to put patients on a drug holiday and take their levodopa away, you would find, although they crash after a few hours, there would be another long, slow decline in motor function as the long duration response goes away. Okay? So 2 components. Now, the smart question somebody will ask me is, how do you get this long duration response? Smart answer, nobody knows. Okay? And that goes for many things in this field. We do not know how this long duration response comes along. Now, why is this important? Well, when you think about wearing off, what you would immediately think is, well, the duration of action of levodopa gets shorter. What's happening is you're losing the short duration response to the drug. Let's have a look. Here's a nice little cartoon. Does it work? I have to press the button. Yeah. Okay, so there's your dopaminergic neurons decaying. You start to put levodopa in to treat the motor deficit. 2 components. A short duration response, and you have this underlying long duration response. Now, what happens is the long duration response in the early stages masks the up and down that you get in the short duration response, so you don't really see the short duration response. But as time goes by, the long duration response decays and becomes a smaller component of the overall effect of levodopa. So instead of seeing a smooth response, you now start to see these ups and downs in the response to levodopa. What you have in the middle, however, is what we believe to be the opportunity to intervene in this process occurring. And if you can start to put dopamine or dopamine receptor stimulation back in a more continuous manner at this early point of the disease, what you can potentially do is you can stop the appearance of these fluctuations. And that's what I'm going to emphasize as we go on through this talk. Now, back to mechanism. This is the classic explanation of why wearing off occurs. Oh, you can't use pointers on back projection, I forget. On the left-hand side, you have the response to levodopa, a single dose of levodopa in early Parkinson's disease. You give the drug, you get 4 to 6 hours of benefit. As you go on through moderate and advanced disease, the response becomes shorter and sharp. Now, what is said is that this reflects the continuing loss of dopamine terminals in the striatum, because in early disease, levodopa and dopamine is stored in those terminals. And what that storage does, it buffers against fluctuations in plasma levels of levodopa that occur over the course of the day. So you have buffering capacity. As the disease becomes more progressive, you lose that storage, you lose the buffering capacity, and now what the striatum sees is much more a reflection of changes in plasma levodopa concentrations with dose and time. So what you've done is you've started to lose control of dopaminergic transmission at the synaptic level because of the progression of the loss of presynaptic terminals. Does that make some sort of sense? Okay? But it can't just be that. And this is why all these things are complicated. It can't just be that, because if you take a poor old rat and you knock out 99% of all its dopamine terminals with a nasty toxin, and then you treat it repeatedly with levodopa, you get wearing off. So there has to be a post-synaptic component to wearing off, as well as a presynaptic component. And the other reason we know it must be post-synaptic components is that you can also see wearing off, experimentally at least, when you give dopamine agonist drugs, which only act post-synaptically. So it's presynaptic, but it also has a post-synaptic component. So what can you do about wearing off if your patients are suffering from wearing off? Well, the common strategies are to try and do things to boost the levels of levodopa or dopamine, use a COMT inhibitor to boost the levels of levodopa, use an MAOB inhibitor to boost the levels of dopamine. You could use a longer-acting dopamine agonist drug, or dopamine agonist, Pinerol, pramipexole. But probably the best thing to do is to try and introduce something which really gives you a more controlled, continuous delivery of drug, because what that's going to do is going to give you back something physiological that works at the level of the synapse. Okay, I'll come back more to drug delivery towards the end, but now let's have a look at dyskinesia and what the mechanisms are that underlie dyskinesia. Prevalence, again, one study from a whole series of studies. The first thing to note is dyskinesia probably not as prevalent swimming as fluctuations, but still affects probably in the region of 20 to 40% of all patients with Parkinson's disease. Although my own feeling is that we don't see dyskinesia in the same way that we used to. I think more careful treatment of patients has reduced the number of people with troubles of dyskinesia. I don't know if that's a correct reflection of what you see, but that's what I see when I talk to patient carer groups. Next thing is components of dyskinesia. This is just a pharmacologist's view of it, but involuntary hyperkinetic movements consisting of chorea, dystonia, athetosis at least, that occur at the time of peak drug action, so peak dyskinesia, although you can get dyskinesia that occurs with the onset of drug action and at the end of drug action, which would be diphasic dyskinesia. And all I'm trying to emphasize is this is not a single phenomenon. We talk about dyskinesia as though it's one thing, but it's not. It's really quite complex. And also, as we heard yesterday, it can be at least focal, segmental, generalized. So it doesn't manifest itself in the same way in every individual. Very complicated. But within that, there's two other things about dyskinesia which are important. Dyskinesia, whatever it consists of, has two components. Firstly, there's the priming of the basal ganglia for dyskinesia. What happens during drug treatment is that a message is laid down for the expression of dyskinesia. And that message is persistent, if not permanent. And that's why once dyskinesia has appeared, every time you probe that patient with an acute dose of drug, the same involuntary movements will appear again and again. And priming is very difficult to get rid of. The second component is the expression of dyskinesia. Once the message is laid down for dyskinesia, then it doesn't matter what drug produced the priming. Once you probe the patient with dopaminergic medication, agonist, levodopa, then you will get that expression. So always remember it comes as two things: priming, then expression of those involuntary movements. Now, let's look at induction of dyskinesia. Why do patients with Parkinson's disease get dyskinesia? It's two things. Firstly, you've got to have nidal denervation. If you don't have any nidal denervation, and I'll show you the evidence in a moment, you don't get dyskinesia. That component is not really in your hands. The second component is in your hands. The second component is the way in which drug treatment is administered can determine whether or not dyskinesia appears in the first place. So these combine to induce dyskinesia, and what it's thought is that if you keep pulsing the basal ganglia dopaminergic drugs, you are more likely to induce dyskinesia than if you continuously stimulate basal ganglia with drugs, because what you're doing with continuous stimulation is you're doing something which is more physiological. And the whole messaging here is don't go down the priming road, because once you've primed your patient for dyskinesia, it's very difficult to go back and deprime them and get rid of those involuntary movements. How do we know nickel denervation is important? Well, this is the evidence. Basically, if you take humans with no nickel damage, you take monkeys with no nickel damage, and you give them levodopa in therapeutic doses, no involuntary movements appear. There are exceptions. If you take normal monkeys and you give them heroically high grams of levodopa a day, you might get dyskinesia. Normal physiological and normal pharmacological doses, dyskinesia does not appear. On the other hand, if you go into humans or to primates who've got a very extensive nickel lesion, you get dyskinesia very quickly. You need very little exposure to levodopa for dyskinesia to appear. So the extent of a nickel lesion is probably the most important factor determining whether dyskinesia does or does not appear. And if you'd like to look at a recent paper, this is from Ali Rajput in Canada. He came across a group of patients, all of whom had been treated for one reason or another with levodopa for up to 4 years. First of all, none of their symptoms improved because they didn't have a nickel lesion. None of them got motor fluctuations, so none of them got wearing off, and none of them showed dyskinesia because they don't have nickel damage. No nickel damage, no dyskinesia. Now, this was a lesson that we learned the hard way, and you may well know that levodopa used to have a terrible reputation for inducing dyskinesia in the treatment of Parkinson's disease and was avoided as first-line treatment. You have to understand why it got that reputation. The reputation came in the early days of the use of levodopa, because before levodopa there was no effective treatment. So patients who had a 10 or 15-year history of Parkinson's disease were suddenly exposed to high doses of levodopa. And because they had a large nickel lesion because of years and years of disease, not surprisingly, all the motor complications that we now associate with the longer-term treatments of the illness started to appear. And what we're seeing in recent years is more careful use of levodopa does not lead to the same high incidence of dyskinesia that was seen in early use. But there's still a mindset that we have to get over. A lot of clinicians say, well, what I want to do with my patient is I want to save levodopa until they really need it. I'd like to save it to later in the treatment. And what I think is that you can take this honeymoon period that you see when you use levodopa early, and you can move it down the disease, and it's of the same width, so that you get the same benefit. But over that period, nickel degeneration is increasing. And so what happens is, the window gets shorter and shorter. And the general feeling now is that there is no case for delaying the use of levodopa if that patient requires levodopa treatment. You're not doing them a favour, perhaps by delaying levodopa, because the same benefit will not appear later in the disease over the same time period. And this is being backed up again by more studies which are coming out of Africa in particular, where groups of patients with advanced disease are now receiving treatment. And we're seeing the same thing that we saw in the 1960s in Europe, and that is they're developing fluctuations and complications within a few weeks or few months of starting treatment because they're so advanced. How do you treat dyskinesia? Well, this is again looking at expression and priming. If you're looking at the expression of dyskinesia, then what you can do is you can reduce the dopaminergic treatment that leads to dyskinesia expression. But if you reduce treatment, then obviously you may be under-medicating them for their motor disability. You can introduce something like amantadine as a glutamate antagonist to suppress the dyskinesia. You can switch to continuous drug delivery, which I'll come back to later on. You can send them for DBS things are very serious. If you want to suppress priming, you can try a low-dose treatment to prevent priming, but again, you have under medication. You can use a dopamine agonist early, but I can tell you, dopamine agonists may not express dyskinesia, but actually they prime the dyskinesia. So when you get round to using levodopa, the patient is already primed, you stop the levodopa, up pops the dyskinesia because you didn't think you were doing anything harmful with the dopamine agonist. You can use continuous drug delivery, as you'll see, to get rid of priming the dyskinesia, or you can do some things which I hope I'll mention at the end, which is you can look at some modern therapies, some new therapies for ways of reducing nigral cell loss, or you can try gene therapy and restore physiological dopamine production. Now, coming out of this is a little story I have to tell, which is why do we use dopamine agonists early in the treatment of Parkinson's disease? Because we never used to. Lots of people were using levodopa, and certainly there was a lot of people switching to use dopamine agonist drugs. The main reason was studies like this, monotherapy studies over several years, which compared the number of patients getting dyskinesia to levodopa monotherapy with the number of patients getting dyskinesia in response to a dopamine agonist. All these studies showed that over the first few years, you were less likely to get dyskinesia using an agonist than using levodopa. And this is what transformed therapy some 10 or 15 years ago. And what you don't see on there is, of course, that levodopa is the best drug for treating Parkinson's disease, and the dopamine agonists do not produce the same degree of clinical efficacy as you see with levodopa, and eventually, of course, everybody has to move on and have at least some levodopa therapy. But this idea that dopamine agonists produce less dyskinesia turned into a concept which most of you will probably know called continuous dopaminergic stimulation. And it basically said you lose tonic stimulation of dopamine receptors in Parkinson's disease. If you put in a short-acting drug like levodopa, you've got a half-life of 90 minutes. What you do is something non-physiological, the brain doesn't like it, you get dyskinesia, therefore you must use a dopamine agonist because these compounds have a longer plasma half-life, and what they do is they give you something which is more physiological. And this was really what led to people, had I started to spit? Did I upset him? And this is what really led to the use of dopamine agonist drugs early. Now, lots of people bought into this hypothesis, but in fact, continuous dopaminergic stimulation as a hypothesis is actually not correct. We have never shown in the clinic, in a head-to-head comparison, that there's a difference between a short-acting dopamine agonist drug and a long-acting dopamine agonist drug. All we've done is compare levodopa to a dopamine agonist. No head-to-head studies. If you look at all the preclinical work, it shows that all dopamine agonists, whether they're short-acting or long-acting, produce less dyskinesia than levodopa. This is a class effect. As I said earlier, dopamine agonists are not innocent in all of this. If you treat a Parkinsonian monkey with a dopamine agonist, but you don't see any dyskinesia, if you switch that animal to levodopa, after the first dose of levodopa, the dyskinesia appears because the agonists are busy priming the dyskinesia, but not leading to expression. And in every experiment that's been done in models of Parkinson's disease, it's quite clear that if you deliver drugs continuously, it doesn't matter whether it's levodopa or a dopamine agonist, you reduce the chance of dyskinesia occurring. So continuous dopaminergic stimulation as a hypothesis is wrong. Continuous drug delivery of Parkinson's disease turns out to be correct. However, it may not just be dopamine. We all say dyskinesia, it's dopamine, basal ganglia, dopamine receptors. But in fact, there's quite a lot of evidence around that serotonergic neurons also play a role in dyskinesia production. What is thought is that we know levodopa goes into serotonergic neurons, and we know it's converted to dopamine within serotonergic neurons. But in the normal striatum, there's enough buffering capacity to take care of that extra dopamine formation. However, when you lose presynaptic dopaminergic terminals, the buffering capacity goes away, and now what you have is uncontrolled, non-physiological release of dopamine from serotonergic neurons. So don't always think this is just to do with dopamine. Other neurotransmitter systems also play a key role. Now I want to go back to something that came up yesterday. If you want to delve deeper into the pathophysiology of dyskinesia, then often you see lovely drawings like this that look at alterations in the activity of output pathways from the striatum. They look at alterations in striothalamo-cortical loop integration. In particular, people have done a lot of work looking at trafficking and signaling and all sorts of things to do with D1 receptors in the striatum and with long-term potentiation and long-term depression. And I can show you a lovely paper that came out recently, 70 pages long, which goes into all of this, which you can read if you really want. But I can tell you, the end result of all of this is that nobody knows precisely how dyskinesia is produced, nobody knows how the different components of dyskinesia are produced, and nobody knows what affects different body parts. Okay? I could give you an hour's lecture to convince you that we did know, quite easily. The real answer is we don't know. However, a nice black box diagram like this is much easier to understand. And all this black box diagram says is that as you lose dopaminergic input into the basal ganglia and it progresses, what you do is you finish up with an abnormal basal ganglia. We don't know what the abnormality is, but it's abnormal and it becomes permanently abnormal to a point where you cannot reverse those changes with any form of drug treatment. But knowing this gives you the ability to intervene at an early stage to put back normal stimulation of dopamine receptors through continuous drug delivery, stop those changes from occurring, and if you do that, then the long-term outcome looks to be better than going on using drug treatment, which is, can I help you back to your chair? Using drug treatment which is not physiological. So, how do you do continuous drug delivery impeding? You can use a longer-acting dopamine agonist, and there's no doubt that pramipexole, ropinirole, or therapy is longer acting than levodopa, but they're not that long acting because you have to administer them 3 times a day and they don't work at night. So they're not giving you continuous drug treatment. You can use extended release dopamine agonists, again, pramipexole, ropinirole, but in essence, they only work for about as long as 3 single doses of dopamine agonists, and again, you haven't got continuous stimulation. You can use the reticotine Neupro patch. If your patients can get it to stick to their skin, and you also can get away from the skin irritation it causes. Or you can go on to device-driven delivery of drugs, which is what I'm going to talk about, and you can use subcutaneous infusion of apomorphine, or you can use an intraduodenal infusion of levodopa. So, the great thing about apomorphine is probably the only dopamine agonist drug which has efficacy equivalent to levodopa. It's a good old-fashioned, dirty drug that seems to mimic more closely levodopa than either pramipexole, ropinirole, or other dopamine agonists. It has to be given by subcutaneous infusion because its oral bioavailability is terrible, and it has a short half-life. But if you use it as a subcutaneous infusion, then it has a pretty dramatic effect on Parkinsonian symptomatology. And I've just summed the evidence for that up in one slide. If you use subcutaneous infusion of apomorphine, you can decrease motor fluctuations because you're delivering the drug continuously. You increase on-time and quality of life. You get some improvement in non-motor symptoms. You might decrease dyskinesia, but the evidence for this is a bit up and down, and you do have continuous drug delivery. The downside is there's a very poor evidence base for this up and